So let's move on now and talk about specific cytokines that seemingly play critical roles in the induction of asthma and in the perpetration of the asthma. Mario, tell us a little bit about IL-5 and the importance of IL-5 in eosinophilic, specifically inflammation.
Sure. Well, IL-5 is a key cytokine because it actually attracts eosinophils to the airway. It causes their proliferation. So these eosinophils migrate from the bone marrow and migrate all the way to the airway and cause eosinophilic specific inflammation. And it certainly also are a number of other cells that are producing IL-5. We know it's produced by the epithelium, it's being produced by the lymphocytes, and these resident cells can produce a fair amount of IL-5. We know because of that IL-5 milieu then attracts other cytokines that are important and other inflammatory cells that are important to that process. And this is often, again, there are some steroid resistant patients that still have a load of eosinophils in their airway.
But in addition to IL-5, other cytokines are also clearly important in asthma pathogenesis and pathophysiology. So interleukin-13 is an important cytokine, again, in asthma pathogenesis. It works through a heterodimer receptor that is comprised of IL-4 alpha and the IL-13 alpha receptor. It binds to that receptor, and it contributes to airway hyperresponsiveness and also plays a role in terms of development of different inflammatory mediators, including nitric oxide is an important marker of IL-13 activity. IL-13 is also involved in IgE synthesis. IgE, as you know, is important in the allergic cascade. And IL-13 also plays an important role in goblet cell hyperplasia and mucus hypersecretion. And it's been shown that patients with high levels of IL-13 in the blood and or in the sputum tend to have worse asthma control. And if you target patients who have high levels of IL-13 in the sputum with an anti-IL-13 antibody, those patients tend to do a little bit better.
Also, IL-13 has the unique property of inducing nonspecific airway hyperresponsiveness of human airway smooth muscle, engendering sensitivity to virtually every agonist, and at the same time, it impedes beta agonists' ability to reverse some of those effects. So it's almost a double-edged sword. So we would anticipate therapies targeting IL-13 or potentially 413 may have a bigger signal on the FEV1 if the airway smooth muscle is a major player as a pivotal cell in regulating bronchomotor tone. Having said this, Mario, what do you think the benefits are of trying to match what we talked about in the pathophysiology to the individual patient for our audience?
Sure, and I think Michael was alluding to her earlier, but we were talking about phenotypes, and clinicians think about phenotypes already. I mean, we think about that patient that has uncontrolled asthma, has nasal polyps and aspirin sensitivity, that Samter's triad, that's a phenotype. And what we've now, I think, advanced the science is really to understand, well, what's the pathophysiologic mechanism that's driving that? And that's what we're referring to now as endotypes. And I think it's really helped us now understand this vast group of asthmatics, that their disease process can be driven by specific pathophysiologic mechanisms, and then that allows us to target that mechanism in a much more effective way.